haven't got any more beard now. I haven't got any more beard. तुला दाढी करायची नको. तुला दाढी करायची नको. आम्हाला दाढी नको करायला. दाढी करायची नको. आम्हाला दाढी नको करायला. त्याचं काय संबंध नाहीये. शाहरुख खान करतो दाढी मूवी मध्ये, त्याचा काय संबंध नाहीये. तुला दाढी करायची नको. आम्हाला दाढी नाही करायची. मग तुम्ही जा. तुला दाढी करायची नको. आम्हाला दाढी नको करायला. मग तुम्ही जा. देवानंद अंकल म्हणतोय आम्हाला दाढी नको करायला. म्हणतो
देवानंद अंकल म्हणतोय आम्हाला दाढी नको करायला. सफिया थोडा आता इथे बोलू नको हा प्लीज.
तो अंकल असं देवानंद अंकल असं म्हणतो.
Italiano. Bye-bye. I think you've got this.
We will just wait a few more minutes. It is just about 5 o'clock. So I think few people are still expected to join. So we will just wait for another at least 3-4 minutes. Danelle, you can start sharing your screen so long.
Okay, Prof.
दाढी करायचे नको. आम्हाला दाढी नको करायला. तुम्ही जा. आम्हाला दाढी नको करायला. मग तुम्ही जा. आम्हाला दाढी नकोय. दाढी करायचे नको. आम्हाला दाढी नको करायला. मग तुम्ही जा. दाढी करायचे नको आम्हाला दाढी नको करायला मग तुम्ही जा नको 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 आम्हाला दाढी नको करायला मग तुम्ही जा दाढी करायचे नको आम्हाला दाढी नको करायला मग तुम्ही जा आम्हाला दाढी नको
I think, Danelle, you can start now because anyway the meeting is being recorded. So those who join late, I can always give them the link for the meeting. I'll just see what is being written in the chat. Okay, that's fine. Okay, so good afternoon, everybody. Let's hope that power shading does not affect our meeting. Today, we welcome registrars and trainees from outside Eastern Cape as well. Dr. Danelle Erwee, our medical officer, is going to talk about child abuse or non-accidental injuries. Okay, Danelle, you can go ahead.
Thank you, Prof. This afternoon, I'm going to speak a bit about non-accidental injuries in the context of pediatric surgery. So with the contents that we will be discussing, we will look at the definition, the incidence, recognition, the presentation, radiology, as well as the management by us and a take-home message, and then also look a bit at the references. So with the definition, there's a big difference between Western and African definition for non-accidental injuries or child abuse. In the Western population, according to the WHO, it's any physical or emotional ill treatment, sexual or neglect or negligent treatment, or commercial or other exploitation that can cause actual or potential harm towards the child's health, survival, developmental, or dignity. All of this is placed in a context of a relationship of responsibility, trust, or power. With us in Africa, the definition differs a bit because of all our different cultures that we have. So they give a definition of abuse to an extent that is not acceptable in the particular culture. So if we can give an example, some of the cultures accept male as well as female circumcision, while in the Western communities it might be seen as abuse towards the female child. If you look broadly at it, both of them agree still that it's maltreatment of children. It can be of their peers as well, but it's normally in someone that has power over them or a responsibility over them that abuses them. So if we look a bit at the incidents, in Africa, Africa has the highest rates of homicide for children under 5 years. For the boys, it's 17.9 per 100,000, and the girls is 12.7 per 100,000. This incidence is 6 times more than in Western countries. The magnitude is even obscured by different legal and cultural definitions of abuse, poor reporting, as well as poor recording of them. So why is children mostly involved? The reason is that children is normally weak and vulnerable. They are very easy targets for abuse. The smaller the child, the greater the danger of abuse, and they also have a higher fatality risk. The highest risk that we've seen is with firstborn children, preem babies, stepchildren, and any type of disabled child. With the incidence, as you can see there, if you look at the right side, the average age for the abuse normally happens at 7 years, but the average age for the fatality cases is normally at 3 years. The physical abuse, you can see there at the top, for the physical abuse, a third of them are for less than 6 months, a third of them 6 months to 3 years, and a third of them children over 3 years. Abuse is also a common cause of childhood death. In the age group of less than 6 months, it is second to sudden infant death syndrome. So when we look at different types of children abuse, there's a few different types. The most commonly known is the physical as well as sexual, but there's also other types. With the physical, that is when there's injuries inflicted physically by the caretaker. There's also a thing that they call the shielding phenomenon. So that is when a child, let's say an adult gets attacked from another person with a knife, and the adult uses the child then as a shield to protect themselves. We normally see those mostly with knife injuries. With sexual abuse, the term is broader than just only child rape. That is any use of a child for sexual gratification. So it can be sexual intercourse, but it can also be touching, fondling, or any other inappropriate contact with the child's genitals or breast. It can also be masturbation in the presence of a child, or masturbation of a child by an adult, or other way around. It can also be any type of body contact with adult genitalia, as well as pornography, including photography or erotic talk. When we look at other forms of children abuse, this is normally the ones that we forget to look for, the ones that we are not, that's not as easily seen. So that can be failure to thrive, intentional drugging or poisoning, medical neglect, safety neglect, emotional abuse, or organized. So with the failure to thrive, normally it's nutritional deprivation that happens mostly in the first 2 years. And 50% of those cases is due to maternal neglect in the 2-year age group. With the drugging, that is when drugs is given to a patient that is harmful or not intended for a child. With the medical care, that happens when the chronic diseases worsen due to neglect of the condition by the caretaker. With safety, that's normally when we see a gross lack of supervision. And then emotional abuse, that is when the child gets blamed for incidents, or when the child gets rejected, or when there's severe verbal abuse. This is one of the most difficult abuses to prove because there's no physical signs that we can see. Organized crime, that can also be present when there's multiple victims and perpetrators. So they can have, that can be the pedophilic and pornographic rings, but it can also be spiritual or social objectives of any of the cult-based groups. So when we first look a bit with our physical abuse, how do we recognize this physical abuse? So we have to look at a few things that can tell us that it is more abuse than an accidental injury. So that is when there's unexplained injuries, when the history is not the same from the parent and the child or the caretaker, when there's a significant delay in seeking medical care, or when there's alleged self-inflicted injury or blaming of the third party. No, but I didn't hurt him, that person did. We can also recognize it when there's repeated injuries or when there's sexualized behavior or STDs, especially when the child is young, when the child shouldn't be having any of that behavior, then we should think of it. Just a few examples, they can say that they just found a child like that, or they're not sure the child might have fallen down, or no, but this child bruises easily, or things that doesn't explain the severity of the injury, like the child rolled over the arm and fractured it. When we look a bit at predisposing factors, there's a lot of factors that predisposes children to child abuse. So if you look at personality traits, that is personality traits of the person abusing the child. So you'll see there's substance abuse, young parents, when they get abused as children, low self-esteem, antisocial behavior. But with this, it's significant to note that 90% of the cases, the parents don't have any psychological problems or any criminal nature. So it's normal parents that can also abuse. With the child characteristics on the right side, 3 years. The reason is they are unable to defend, they are small in relation to the adult, and they require constant care and attention. They're also in a learning phase, so they are not responding as expected, and that can be frustrating. With disabilities, they can have cognitive, emotional, or physical disabilities. And with the premature and low birth weight, it's suggested that there's a interference with the mother-baby bonding. Let's say a premature baby is born, they need to stay in NICU, they don't breastfeed as often, so that can have a significant impact. When we look at the family dynamics, it's a lot of things that happens in South Africa as well as Africa. Family breakdown, single parents with an absent father, large families that live together, and domestic violence. When domestic violence is documented, there's a 30 to 60% chance that that child is being abused at home as well. When we look at environmental factors, they are connected to scarcity of social services. As you can see, that's also everything that's happening in South Africa as well as Africa. So that is why we have this high incidence with us. Consequences of abuse is not only the physical trauma that it causes, but it causes also quite significant emotional trauma. So the victims can have substance abuse and depression, and those are 2 to 3 times more likely to happen in the children abused than any other. They can also show physically aggressive behavior towards their peers, and that can influence on their adulthood. So 30% of these children also abuse their own children. Some people have suggested that this cycle can be attributed to changes in the neuroendocrine system, and that influence the child's arousal, learning, growth, and pain threshold. With the presentation, as you can see on this slide, there's a lot of different presentations. So the child can come in with various presentations. We won't focus on this slide, but we'll focus a bit more on physical and then look a little bit on the other ones. So if we first look at the not physical presentations, because I feel these are mostly the ones that we don't pick up as easily. So when we look at emotional and behavior indicators, they can have aggression, withdrawal and anxiety, irritability, bullying, and they can also have an unwillingness or tearfulness when they undress. When we look at the physical, psychological, or sexual abuse, these patients can have failure to thrive, as we said. They can have stuttering when they speak, not reaching their developmental goals, and when you look at them when they are away from home, you can see that they actually are thriving. With the presence of the indicators of the deliberate neglect, these patients can be underweight, they can have bed sores, disorientations, and sores in and around the mouth. A study was done at Red Cross Hospital in January 2008 to December 2010. This was a retrospective study, and it reviewed children, between 0 and 30 years. The aim of the study was to describe the population of the children that presented to the Red Cross trauma unit with non-accidental injuries. And in this 3 years, they had 522 cases. Of all these cases, the occurrence was more seen in males than in females, except for sexual abuse, where there was 93% female and 6.7% male. So the highest number of non-accidental injury cases was also recorded amongst the 5 to 9 year age group. Like we said, the average age of presentation, or the average age of abuse, is at 7 years. So that we also found that in South Africa. So when we look at injuries that they present with, the injuries are mostly that they presented with was head injuries, that you can see there at 35.3%. Second was facial injuries, that was 16.3%. Genital injuries, that was 10.5%. That is not the sexual assault, but genital physical injuries. And then lower body injuries. With the South African presentation again, where it happened, it's actually very shocking to see that even with the physical as well as the sexual assault, the place that they happened most oftenly was at home. Sometimes even with physical, they can happen at school, public places, as well as other places. When we look then at the physical injuries per organ system, When we look at the skin first, they can present with bruises, burns, and bites. With the nervous system, they can present with head injuries as well as ocular injuries. With the skeletal, they can present with fractures, and they can also have abdominal injuries. With the skin, as you can see with these photos, when there's a bruise on the cheek and the face, it can indicate that the patient was slapped or hit with a fist. The grip bruises is when a patient gets shaken around or gets held there while something happens to them. The buttock and back bruises often is related to punishment, and it's very difficult to determine the age of the bruises. You can see the cigarette and the pinch bruises there as well. With the maturation of bruises, you can see it's very difficult when it's on a child. It always looks easy when you have it here like this in colors, but it's very difficult to distinguish between red and reddish purple and purple. So for the first 24 hours, it normally presents as a red bruise. Within 24 hours, it changes then to a reddish purple. With 24 hours to 1 week, it's more a purple color, and then 1 to 3 weeks, you can see a combination of yellow, green, and brown. This is secondary to the degradation of the hemoglobin that you get that combination of 3 colors. With the burns, the way they present is when there's forced submersion into a fixed position. As you can see there, the bums is on the surface, so that is why you get that donut hole sparing sign. And then the abdominal skin flaps is there where the zebra stripes are. So those are spared from the burn, and the rest gets a pattern like this. When the child is also pushed into hot water with the hands and the feet, they get a glove and stocking pattern. And there's also specific things that you can look for, like a clothes iron or a curling iron, cigarette burns. This is just a picture to show the glove and stocking pattern. You should also look there with these, the patients normally has absence of splash marks because they are held there with force. They can also have signs of upper limb restraining while this happened. With bite injuries, you can see distinctive tooth marks, as well as you need to photograph these tooth marks because it's very helpful to keep it for forensic evidence. With head injuries, the incidence is about 70 to 40 per 100,000. The largest group of the head injuries is seen in infants of the age of 0 to 3 months. And a third of them we don't even recognize. The reason is that it's very difficult to diagnose head trauma below 3 years, especially when there's no external injury. You should always have a high index of suspicion of this, and worrisome history is when a child comes in, the parent says, no, it was a low fall, the child walked and fell off the step, and then the child comes in unconscious. We can also see with them skull fractures as well as subdural hematomas. When there's repetitive injuries, they can also have brain atrophy. When we look at the shaken baby syndrome, the name was changed to abusive head trauma. This syndrome is caused by either shaking alone or shaking with impact. That magnifies then the forces of the acceleration and deceleration. This results into HIE or the cervical nerve disruption, or it can resolve into both. So as you can see there, the triad is retinal hemorrhaging, brain swelling, which presents with encephalopathy, as well as a subdural hematoma. When we just look a bit at the mechanism, there's hyperextension and hyperflexion. That causes then that the gray matter moves over the white matter, and that has the shearing force causes then axon damage. As you can see here at the axonal shear injury, the damage is then at the axon cell, and then the brain cell above that dies, as well as the axon. So then it causes axonal injury for the brain, and that's why a common finding is then that the child has brain edema with the loss of the normal white and gray matter differentiation, and that presents clinically as encephalopathy. The rapid acceleration and deceleration can also tear the bridging veins, and that results into bleeding, and that's the cause then for the subdural hematoma. The subdural hematoma can then often be bilateral. With this, when we discuss the triad, the retinal hemorrhages are nearly always present in a shaken baby syndrome, so it's important to look for them. With the ocular injuries, it's very difficult to diagnose these, especially because we are working with children. We might not be able to dilate the pupil because we don't have dilator available. So it's very important to have an input from a specialist ophthalmologist, because there's also a complexity in diagnosing these injuries and we don't see them often. So the first one, as you can see, the first picture, that is an example of a retinal hemorrhage. So you can see the two hemorrhages, and the one with the white spot inside is called the Roth spot. The second one is when there's lens dislocation, it can dislocate anteriorly. And the third one is retinal detachment. As you can see, that dusky area is where it detached from the retina. So with the skeletal injuries, fractures is rare in children. Fractures over less than 3 years of age, you should always suspect abuse. And 25% of abuse cases involves skeletal injuries. A pathognomic fracture is a bucket handle fracture, and which we'll look at now. And some worrisome signs is when you find a child that has different stages of healing of the skeleton, or there's fractures of the diaphysis of lung bones in the infants or the children, and they can't even walk. So with the skeletal fractures, this is an example of a bucket handle fracture. So you can see there on the left side, there's a Volgian fracture of the corner of the metaphysis from the periosteum, excuse me. That happens when the long bones gets wrenched. And then approximately 10 days after that injury, there's a calcification of that subperiosteal bleeding. That is when you'll see that classic double cortex line, which you can see there on the right, because of that calcification. So if you see this, it's abuse until otherwise proven. So they also did a study at Red Cross. It was during a 14-year study period. Almost 100,000 trauma patients were treated at Red Cross that time, and about 1% of them were confirmed as victims of non-accidental injuries. More than 2/3 of these cases were males, 64% of the cases. When we look at the age groups, a quarter of these children were younger than 6 months, and 38% were older than 3 years. When we look at which area the anatomical areas most frequently fractured, we could see that the head and neck was involved the most, that was 53%, and then the upper limbs, that was 24%, as well as the lower limbs, that showed 18%. Only 7% of these fractures were in the trunk, so we don't see them as often. It's mostly head, upper limbs, and lower limbs. With the abdominal injuries, solid organ rupture can happen when there's direct blunt impact on the abdominal organs. So they are high-risk organs. The reason is that the abdominal muscles, the younger the child is, the more fragile they are, and the less protection they offer. They are very easy to compress against the spinal column, and they can have a variety of further injuries that can also even affect the small intestine. So with our differential, we should look at birth trauma. That is a history from birth. Congenital syphilis, that will show other things like positive blood test, a chronic periosteal reaction, and metaphyseal widening, as well as osteogenesis imperfecta, but you will see then blue sclera, osteopenia, and multiple fracture. Ricketts disease, you might see the bowed long bones as well as blood abnormalities, and they have renal disease. Scurvy, you can see with poor wound healing, bleeding gums, and petechia. Skin disease, you can see other types of skin disease like impetigo, and then the accidental trauma. That's why we need to get the history from the parents to look at the pattern of injury and then to see how the parents interact to try and differentiate that from non-accidental. With sexual abuse, we won't be talking a lot about this because this is a whole topic on its own. So just a few points on that. Signs and symptoms that you should be thinking about. Recurrent abdominal pain, difficulty walking or sitting, painful micturition, fecal soiling, and the signs is when there's any discharge, any abnormal dilatation, when there's lacerations and bruisings or bleeding, and then any signs of STIs, you should also think about that. With sexual abuse, the examination should never be taken lightly, and they should be performed under ideal circumstances, because if it's performed under other circumstances, it might contribute to the secondary trauma of the child. So it should always be done by a qualified doctor, and then a specific protocol should be followed. So a private area is needed, a third person, either the mother or a sister, hopefully always a sister, can be present. You need to explain the procedure to the mom as well as the child. You need to first do a general exam to gain the child's trust. It should only be done once, and you should note the stage of sexual development. If there's different types of examination positions that you can use. If it's a smaller child than these pictures, the child can be examined on the mom's lap with the back to the mom and the mother holding the leg south. Older children can be then examined like the first picture, the frog leg or the supine lithotomy position. The anus should be examined in the lateral decubitus, and the right side that you can see here is the knee to chest. They're advised against using the knee to chest position because a lot of perpetrators use this position themselves. So all children with evidence with perineal trauma should be examined under anesthesia to determine the nature, as well as to see if there's need for surgical repair. When we look at the global incidence of sexual assault, in 2009, there was a study published in the Clinical Psychology Review that showed the global prevalence of sexual abuse in children was an estimated 19.7% for females and 7.9% for males. Africa then had the highest prevalence of sexual abuse, that was 34.4%, and of these countries, South Africa was the highest. So with the management by pediatric surgery, the ATLS protocols or principles should be followed. So that would be your primary survey. You need to resuscitate and treat life-threatening injuries. So that's your ABCDE. Then you need to do your adjuncts like your chest X-ray, pelvic X-ray, your bloods, the FBC, CUSP, CK, and cross-match. Place the NGT if it's needed, a urinary catheter, and IV lines. The secondary survey should include a head-to-toe examination to see if there's any other older injuries. And with the transfer, we are mostly the serving facility, so we should ask for appropriate packaging and accurate handover if we need to hand over. So with the history, patients can present with poor eye contact, withdrawal, they can present with answers that they think will please us. We should have a look for or ask for predisposing factors, and it's very important to ask for previous medical and surgical history. The reason is that possible medical causes like ITP we should try and exclude that already on the history. With the exam, as we said, a full head-to-toe exam, that's also to exclude other medical causes, look at the growth parameters to see if there's a failure to thrive, a general exam of all the systems, detailed examination, fundoscopy, which we normally struggle with when the child consciousness is suppressed, look at the sexual development, and look at anogenital exam for possible sexual abuse, as well as signs of intoxication and drug abuse. With the special investigations, so when we have bruising, we should do an FBC and clotting profile to see if it's not medical. With fractures or long-standing abuse, a skeletal survey where it's available. Neglect and malnutrition, we should check the serum albumin, and then alcohol levels of suspected alcohol intake or serum glucose. When we look at the radiology, we should do a skeletal survey. So that's a chest X-ray, skull X-ray, and the APs of the extremities. The radionuclear bone scans are more sensitive, but under 1 year of age, they are unreliable. So for the X-rays, we look specifically for rib fractures, skull fractures, buccal handle fractures, and old fractures. The bone scan can show us nicely if there's fractures in different stages of healing. It's also very important to refer because we need to have a multidisciplinary approach. One of our most valuable assets is the social worker because they can help us to ensure child safety and to organize a place of safety. This is very important as sometimes when it happens and the perpetrator is at home, the child can't go back home. So then at that stage, the hospital stays the place of safety until the social worker can arrange a different place of safety. So that's why we see some patients stay very long with us. When we look at the socio-medical legal management as well, things that you should do and don't do. So we should recognize it early, we should document it adequately because they use it for prosecution, and we should report all cases. We shouldn't confront and accuse the parents because it hinders treatment and rehabilitation, and there's no place for that in our management. So with this, we should be taking notes with detailed sketches of all injuries and scars. Every page, we must make sure that the child's name and date and folder number is there and that everything is legible. We are responsible for filling in the J88. It's also advised to keep a copy for ourselves, and it's important to write down the name and address of the person accompanying or the police officer that brought the patient in. With the healthcare worker responsibilities, we conduct the forensic medical examinations. We do administer relevant tests. We collect the forensic evidence. We provide medication, and we record all our findings. When we look a bit at the South African law, the South African Children's Act, that was number 38 and 2005, defines a child as any person under the age of 18 years. According to South Africa's population, that 38% of our population is children. And for this, we have alarmingly high statistics for crimes against children. Just for an example, in 2012 to 2013, there was almost 500 cases reported of crimes against children. The literature also indicates that these crimes are even underreported, and they say that they think the cases should be about 9 times higher. The reason why that's underreported is that there's a misunderstanding of the child abuse reporting, there's a lack of knowledge, and doctors have previous negative experiences with child protection services. Some doctors even believe that it's better to deal directly with the family, and they may fear potential harming of their professional relationship. I feel that that is more for private sector. With us, that's not one of our main fears. Research that was done into rape in South Africa then revealed that 84% of these sexual crimes committed against the children, the perpetrator was known. So further, if we look at liability and accountability, according as well to the Section 110 of the Child Amendment Act, the professionals, particularly healthcare professionals, can be held accountable if they don't report abuse of children. This reporting should then be done with the set of facts, so everything that you can pick up while you examine the child, and it shouldn't be done under malicious intent. If that happens, then it will not give rise to any claims of liability. With accountability, the HPCSA as well as the justice system can hold us accountable for this. So the HPCSA can fine us, or they can suspend us for a period of time, or they can even remove our name from the register if we get found guilty for not reporting. The justice system sees a failure to report sexual abuse or exploitation of children as well as mentally handicapped persons as an offence. So that is punishable then with a fine or imprisonment of up to 5 years, or both if the person is found guilty. Something that's scary with this, that 30% of perpetrators end up in court, and only 7% of them face prosecution. So with this, my take-home message is that the definition differs from the Western to African context. Children are easy targets. There's different types of abuse. We are used to physical and sexual, but we often forget about the other type of abuse. Management of the abused patient is mostly multidisciplinary, and the social worker is a very, very important asset that we should use. We should identify children at risk, and any child below 3 years of age are at the highest risk. The leading cause of mortality is head injury, and we should suspect that in any cases of unexplained injuries, discrepancy in history, delay in seeking care, or repeated injuries. And we as healthcare professionals are required by law to report these cases. So we do have a big responsibility. The doctors, the nurses, the multidisciplinary team, all of us have a big responsibility. So these are my references. And it's our job to keep the children safe. Thank you.
Danelle, that was an excellent presentation, a very good summary of problem of child abuse and non-accidental injury. Unfortunately, we have a sad distinction of being the child abuse capital and sexual abuse capital in Africa. But anyway, very nicely presented. I will now just invite one after the other our consultants to comment, and they can even ask questions. First, I will invite Dr. Manikchand. Yashoda, please, you can unmute yourself and make comments or ask questions.
Hi, yes, Prof. Thank you. Thanks, Danelle. That was a very comprehensive, good talk. I think you covered most of the things I would have wanted you to. It's a very cringeworthy topic. I think everyone was kind of probably very affected by everything you said there. It's not something we like to think about, but it happens, and we, like Prof said, we have a high incidence in this country, and as you know, we have a lot of cases coming to us. One of the things, you shared some of the statistics that are really shocking. One of the statistics I came across was that 84% of all sexual crimes are against minors or children under 18, which really shocked me. And then the other thing is that the Children's Act you talked about in 2005, in order for that to be implemented, we need at least 70,000 social workers, according to the Minister of Social Development. And in 2012, I don't know what it is standing at now, but it was much, much less than that. It's only 16,000 registered social workers. So you can imagine what we're dealing with here. We have high numbers, high incidence, and poor social services to deal with these things. So the other thing I wanted to ask you, if you came across any indications for the skeletal survey.
No, Dr. Manikchand, the information I read didn't say, didn't speak
and nothing
about
specific
that.
about ages and things.
No, they only said that the bone scan, the radionuclear bone scan, is not reliable under 1 year. And that's the only thing that I came across.
Okay, so maybe what I've got is old, old stuff, and you've been looking at newer stuff. But I got that a less than 2-year-old with any evidence of abuse should have a skeletal survey. Any child less than 5 years old with a suspicious fracture, and any older child unable to communicate, so mentally impaired, would need a skeletal survey if they come in with trauma. And if the suspicion remains high even after the skeletal survey, then you can do the bone scan because it's more sensitive. Okay. You didn't come across any of that?
No, I didn't.
Okay. This was, I did this talk a while back, just looking at everything. So yeah, it's a big problem. And the other thing I wanted to mention was that, you know, we have children coming in with unexplained incontinence. So you mentioned the fecal soiling, but also urinary incontinence. We had a girl recently, actually, who, you know, we kept for a while after sexual abuse reporting. And just by being in a safe place and away from that environment, she improved, and even her mood and affect improved. So it's really important for us to pay attention to these children who are coming with symptoms that don't really fit in with the presentation, because it could be psychosomatic, psychological, and emotional. Oh, and then the other thing I wanted to mention, you talked about the retinal hemorrhages and the ocular signs. So I also came across that you can do an MRI if that's proving to be quite difficult in a child. And it has an 80% sensitivity. So I don't know if you came across that, but that could solve a lot of problems. And the other thing was that there is a differential diagnosis, like you did mention, like bone problems, metabolic problems, and bleeding disorders. So I think you did go through that. Yeah, and I agree with you. It's it's our priority to keep the children safe. It's a silent pandemic, and we have to pay attention to red flags. And we must remember that we are responsible for mandatory reporting. But thank you. That was a good talk.
Thank you, Doctor.
Yashoda, thank you very much. Those are excellent comments and very pertinent. And unfortunately, it's an ongoing silent pandemic in our country. And we really, as you said, we have a lot of responsibility. Now, can I invite Dr. Majola to make comments, please? Dr. Majola? Kululeko, Dr. Majola, are you still there?
Yes, I am here. Can you hear me?
Please, yeah, go ahead, please.
Yeah. Hi, everyone. Thanks, Danelle, for a good talk. I agree with Yashoda when it comes to skeletal survey. As you said, what we mostly used to practice and what they practice at Red Cross is any injury that is not according to the given history. They will do a skeletal survey on that patient. And for them, it's quite easy because they've got low docs in the trauma unit. So any child with suspected physical abuse with probably suspicion of fractures, then they'll just do low doxes on all those kids. And they have a high, obviously, pickup rates with multiple skeletal injuries on those patients. And then with the bone scan, it's more of an advance if they still suspect, they still have a high suspicion of injury in the patient, but with the x-rays or the low toxins or the skeletal survey, they can't pick up any of those injuries. Then they will do a bone scan on those kids. That's all for me.
Thank you. I'm glad that you mentioned Lodox. I believe we have Lodox at Frere Hospital, but its software has not been upgraded. So that is something which we will take it up with the radiology department. But thank you, Kululeko. Dr. Machaya, Selo, please make comments.
Oh, hi. Thanks, Danelle. Good talk. Covered relatively everything. I just want to ask, what do you think about all the kids that come in burnt in our unit? Is it just negligence, abuse? Do you think we're doing enough to try and actually deal with this, or is it just something that happens? People get burnt and we get over it. What do you think?
I think it's a very fine balance, because the reason is, in our African context, we have a lot of people living in the same areas, very close to each other, not having electricity. So it's normal to have a fire going on. And it's not always, I mean, you can't expect of any parent to always have their child under direct vision. So with the circumstances that we have in South Africa and Africa, I feel that there's a balance between what we can expect and what falls under negligence. Let's say there was a case that came in a few weeks ago where children played, and then the one girl was playing with the fire, putting her dress, a part of her dress in, and then it caught fire, and then they will put sand again on, and that will go away. And they continued to do that for about 5 times, and on the 5th time her dress actually caught fire and they couldn't stop it. And I feel that is negligence, because with that, there should be someone supervising, and the children should be taught about that. But if it's a house fire and the fires inside was cooking and the pot fell over hot water and the child I think in our South African context, it's very difficult to put a firm line between negligence and what is acceptable with the conditions that we live in. So it's a very, very difficult.
Yeah, it's a fine line. Yeah,
Yeah.
because it's very difficult because if you were to look at in a first world setting and look at our setting, typical example is someone gets shot. In South Africa, you hardly ever report that to the police. You just deal with it and you move on with your life. In most of the other centers, it's a major thing. So I think the onus is on showing or highlighting that certain behavior cannot be tolerated. Fair enough, people get burned by accident, that's fair. Sometimes though, when you actually listen to the history, you can find out that there is some elements of negligence and it's unavoidable, unfortunately, because of the social economic status where maybe the mother was not available at that time, just had to go to the shop to buy something, left the child alone, the house burnt down. It's not necessarily something that we want, but it's completely preventable. And obviously this has to go part and parcel with improving social care within our having to improve social care within our environment, because with enough social worker, enough psychologists, you find that we approach it in a more holistic fashion, because what happens now, we have a tendency of sending people to the social worker just to say, okay, we did our part, we sent them through to the social worker, let's move on. And that's a bit of a problem, because even the social workers, sometimes they're overloaded and they don't really try to actually address all the causes. They just want to make sure that where the child is going, it's safe. Then they leave it at that. Where you find instances where the perpetrator lives next door, but because the mom is saying, no, it's fine, you can go home, the social worker are very happy with the child going home with the mother, as long as the mother will watch the child. But the problem is that the issue is not sorted because the perpetrator is next door. The social worker did not deal with the perpetrator, and not enough support is kind of given, not only to the patient, but also to the social worker themselves. So I think in our context, child abuse is rife because there's not enough support, not just to social worker, but to every healthcare worker that's involved. And yeah, I think that the important thing with any kind of abuse is just to report it. Any kind of suspicion, report it, because if, like you said, if there's no malice behind your reporting, you can't necessarily be prosecuted for it. It's better to be proven wrong with your suspicion than to actually leave a child to succumb to systematic abuse from the parents or the neighbors, if it comes to that. Yeah. So I think the important thing, just be able to suspect abuse, mention, or hey boy, no, mention, then refer appropriately to the social worker or to the relevant people thereafter. Okay, thank you.
Selo, that was very good. You brought out very pertinent ethical issues. There is a question for you from Kirsty. Knowing the lack of social workers, what other options or ways are there for us to intervene? Can you answer that, please?
The thing is that I think we try to remove the patient from the cause, so
Yes.
from the source of the abuse. So the way we can do it, even with decreased amount of social worker, is by actually keeping the patient in the hospital for as long as possible, because that just moving the patient away from the cause is actually helping. Then that's why we have situations where patients stay for weeks on end in our units, just because we are trying to make sure that the social worker addresses the issue properly. So I think that's the first step, because only if you I think are really, really, really worried about the safety of the child, and the social worker is not necessarily helpful at that stage, obviously with the consent of the parents, unless if the abuse is coming from the parents, then try to escalate it, move higher than the social worker, go maybe to the police service, just inquire. I don't think there's anything wrong with inquiring and saying that you are suspecting abuse. Social worker is not necessarily not helpful, but is not escalating things the way you want it. And if that's not working, you can go higher up to the court level, because with certain situations where a child maybe needs a blood transfusion, but they're a Jehovah's Witness and the parents are refusing that, you can go up to the high courts and the high courts can give you permission. Obviously, it will be detrimental to the child because the parents might end up disowning the child, but end of the day, we are trying to actually, we're thinking in the child's benefit. We're not trying to push our own agenda onto the child. So we want the child to have a good outcome. We definitely would not want to have a child misplaced from home or to suffer from our assessment. But I think with our social workers, keep them as long as possible within the hospital, so that they actually will get seen by a social worker, involve a psychologist as well at the same time, because it's not just the social worker needs to get involved, it's a psychologist as well, just to give adequate support for that. So prolonged stay in the hospital, that would be my suggestion with no social workers and stuff around. Thanks.
Yeah, thank you, Selo. I think I agree that just the girl who was admitted with urinary incontinence recently, we did the same. No, thank you, Selo. Just one more thing I would like to add is, always, as in any other injury, there is a pyramid. So what we actually see is the tip of the pyramid. So under this, there are many, many more cases which are red flags, but which are being missed in the community. And I think we need to be more alert and aware about recognizing those near miss cases which don't even present to the hospitals. Is Dr. Coppola still around, Funeko? If you are around, you can give comments, please. Is Dr. Coppola still here? I saw him joining. But if he is not here, is Dr. Anna Marie Houghton still here, pediatrician? No, I think she has also left. Yeah, Kirsty is saying that Tutuzela, not only for sexual abuse, but other abuse as well. And they have counselors. Yes, we Tutuzela centers are a blessing. They are a big help. So I think if there is, are there any comments, any questions from our registrars, medical officers? Any other questions from any of the guest people from outside East London?
Prof, I have a question.
Yes.
Yeah, Selo touched on it. One thing I found really difficult, not just here, but also other hospitals I've worked in, if we really do suspect a case, like a burn patient that looks like he's been dunked in hot water, or really suspicious history of what has actually happened, we've referred many of those patients to social worker, and they come back as social circumstances are fine. But everything says, no, it's not. I don't know if we can actually escalate that to the courts. Who do we talk to? Who takes over from there? Because otherwise we just end up sending those children home, knowing that this is not a safe place to go home.
I think Selo has partly answered that, but maybe I will invite him to answer your question. Selo, please.
I think the ideal thing to do, as you said, we start off with the social worker, because social worker should be able to connect us with the relevant parties. If not, then we, as you said, we think it's a criminal offense, so we have to report it to the police station. And should there come a point where the police people find that they're not necessarily helpful per se, because police would be able to link us up with further people who are involved with child persecution and so forth. So they would ultimately be our end cause, because they will definitely link us with the higher courts, so that we can challenge anything. If it comes to a situation where the parents are fighting us, but we are actually pursuing this because for the better welfare of the child. So it would be a situation, it would be a long drawn out situation, but we would not necessarily be the ones pushing it per se, because the social worker would be able to, should be able to guide us in this, because one, the facilities, they'll probably want to put the child in a place of safety, and the only thing from the medical side that we can do is definitely give adequate or write adequate documentation and have adequate pictures if we need that, so that our case is substantiated. But for us to go straight to the high courts would be very difficult without going through the system of the social worker, then the police station, then move on that way.
Yeah, it seems very, I don't know if I got time to go to a police station and report cases and follow up for months afterwards.
No, I think we just can't give up. These are the ways which we can tackle these situations.
The nice thing is that most hospitals, if not all, they actually have police services within the facility. So you don't necessarily have to drive out the hospital. Some, or generally most facilities should have police services within the facility. So that's what I'm saying, that it's tedious, yes, sometimes, where you have to be more proactive than usual, because sometimes just writing social worker consult is where we always end, unfortunately. Instead of social worker following what the social worker is saying, then escalating it higher up, because throughout my experience, there has been very, very, very few cases where the social worker has actually escalated things to police services. They always try to mitigate and actually see where the problem is. And I think the social worker ultimately wants to maintain the family dynamics by not splitting it up, where when you look at certain nations, the thing is to make the child safe first, and the first thing they do is remove the child from the source and put them in a home. Then they sort out the home issues, then they bring the child back once it's safe. Versus us, where should the child be removed from the home, they most likely won't find a place to stay, and it will be very difficult to reintegrate them back into that family dynamic. So I think the way that our social workers operate might be a bit different. Obviously, I can be corrected because I'm not a social worker, but I think it's a bit different from how other units or other first world centers do their thing.
Okay, I see good comments and advice from consultants in the chat box also. So I think if there are no further comments or questions, I would like to conclude, and I would like to thank Danelle for presentation, for all the consultants for their valuable advice, and welcome all the people who from outside Eastern Cape have actually made an effort to join these meetings. We appreciate their presence, and I hope they find the meetings helpful. So we will put out a message for next week. It will be vesico-ureteric reflux, will be presented by Dr. Neha Gautam, but I will set up an invitation and send it to everybody. Thank you, everyone. We are in good time, and luckily ESCOM didn't play havoc, and we had a good meeting. Thank you. Bye-bye. Anybody who is not able to attend, I have recorded it, and I will be putting a link on the group. There is a last comment from Dr. Majola that it is important to engage other parties as appropriately to manage the case. That's also important. Okay, bye-bye now. See you next week.